Welcome to Mama Toto Docs. I'm Dr. Martha, the pediatrician.
And I'm Dr. Lisa, the obstetrician. And we're Dr.
Moms.
We're
Dr. Moms, yes. Today we're going to be talking about labor, delivery, and the newborn period.
Yeah.
So Lisa, how do you know you're in labor?
So basically, how you know you're in labor, the most common one is contractions. So you feel contractions, and that's a tightening of your belly, some intense low abdominal pain that sometimes can radiate to the lower back as well, and then it will be regular. So in third trimester, some people have what we call Braxton Hicks contractions, which are not as regular. Maybe when you lie down, they disappear. You take a shower, they disappear. But when you're in established labor, or when you're even in labor, then those contractions will be regular. So you'll probably be feeling them every 15 minutes or so. Nothing is stopping the pain, whether or not you take a shower, whether or not you drink tea, they're still continuing. So that is now one of the components of labor. Apart from that, we usually say when the cervix has changed in its dilatation, so basically it's opening up, but there's no way for you to know that unless you're checked. So we define it as if you're having these contractions, you are probably in labor, or if your water breaks. So not for everyone should the water break, so no one needs to sit at home waiting for the water to break. But if your water breaks, which will feel like a warm gush of fluid that is significantly more than your discharge, it will feel like maybe you've urinated on yourself, then you come to hospital immediately. You don't sit at home waiting. So that's the definition of labor, let's say in layman's terms. But for us scientifically, we say that when in the presence of contractions, when there's a change in the cervical dilatation.
Okay. And when should you go to hospital, or when should you call your doctor?
So you should, let your doctor know immediately, but whenever you're in doubt, just go to hospital immediately. Go to hospital when you're having these regular contractions, if your water has broken, or if you're experiencing any of the danger signs, which could mean that you feel like your baby is not moving or not moving as they used to before. If you see that you're bleeding significantly, or if there's any blood, you come to hospital immediately. If the pain is not, you can't even describe it as contractions, it's just very severe pain, you must go to hospital immediately. So either the labor signs or the danger signs.
Okay.
Yeah.
All right.
Yeah.
Okay. And we've talked about regular contractions.
Yes.
And drainage of
liquor. Yeah.
Okay.
Yeah.
And what happens? What should I expect when I go to hospital?
Yeah, so when you get to hospital, and ideally when you're going to hospital, I'm sure you've planned from before that you're going to have your birth partner. So it can be your spouse, it can be, a relative, whoever, even a doula, but it's very important for you to have that support, so that they support you all through labor. Nowadays, hospitals allow only one birth partner, so you can't have two and so on, just for control of infections and all of that, especially in this time of COVID. So one birth partner who should come with you to hospital. Your bag that you've already packed from before, you must come with it, and then you get to hospital. Of course, you'll say that you believe that you're in labor. Immediately what happens is that you're taken in. We listen to your baby's heartbeat. We use something called a CTG, which
what
is
does CTG stand for? Daktari.
Yeah, it's a cardiotocograph. So basically, it's a machine that you attach. It has two parts. One is checking for your contractions. One is listening to the baby's heartbeat. Then you let it run. It has a trace, so it runs and runs and runs as we observe the baby's heartbeat over time, 20 minutes to an hour. And so that one shows us how the baby is, how the baby is doing, if there's any distress, if the heartbeat is stable, and also to show us how your contractions generally are. It might not show us the strength, but at least it will show us if there are contractions or so. So that's important. Not all hospitals have CTGs though, but the most important thing is that the baby's heartbeat has been listened to. And especially before and after a contraction. So baby's heartbeat is listened to. Of course, as the mother, you're generally assessed, your blood pressure is taken, your pulse, your temperature as well. And then to now further check and see if you're in established labor as we had defined before, we do what we call a vaginal examination. So vaginal examination, someone puts their fingers inside, it is uncomfortable for sure. Let's not say that it is painful, but it is uncomfortable for us who have experienced
Yeah.
it. But it's just a matter of, I think a trick that women should use is just to take deep breaths in and out.
Yeah, how can
just
you
to relax.
how can you help yourself at that
Yeah,
point?
yeah. So at that point, it's to relax.
Yeah.
Because we always say that if someone is trying to, they're trying to examine you, their fingers are there, and then you have your pelvic muscles that you're busy also clenching. It makes the discomfort even more. So always
just take a
to
deep breath.
Deep breath in and out,
Yeah.
in and out. You just keep doing that. You will end up relaxing, and just tell yourself, this is it. This is the only way for us to tell if you're in labor or not. So you just relax through it, and they will be uncomfortable, but they will not be painful or as bad as you think. Yeah.
Okay.
So that's what happens. So someone puts their fingers to determine the dilatation, and that is the only way to check if your cervix is dilated or not. Yeah, so that's usually done. It can be done by whichever healthcare professional is there. So whether it's a nurse or the doctor, it's okay.
Yeah. I'm just wondering if you could show us, like practically,
Mm.
like when you put your fingers inside,
Yeah.
when you tell someone, oh, you're 2 or 3 or 4 centimeters, what that looks like.
Yeah.
Maybe so that people can.
That's true. So,
get an
I mean,
idea.
we all have different widths of fingers, but the
Yes.
assumption is that one finger is about
About
2 centimeters. Yeah. So 2 centimeters is if someone goes in and then you find that you can't even put a second finger in. It's only one finger that's able to go in. That is 2 centimeters.
so the cervix is up here.
Yeah, the cervix is up here, and you sort of try to push your way through, and then now you find that that's 2 centimeters.
So that's 2 centimeters dilated.
Yeah. And then 4 centimeters, it's now 2 fingers, so that is what you would find through the cervix. Yeah. 6 centimeters. So now from there, we don't put 3 fingers, we just use our 2
Widen,
fingers, and it keeps
exactly.
widening and widening until you're fully dilated. Yeah. There are those. Well, that's, I mean, patients don't get to see it, but there are there's a board that usually has circles to show dilatation. But even you see it on the internet just to see. But basically, it's the 2 fingers that are used to go in and measure, and that's how we measure.
Okay.
Yeah.
Okay.
Yeah.
Good
Yeah.
to know.
Yeah.
And then I can add for CTG, the normal heart rate for a newborn
Yes.
fetus is 140 to 160. We don't want it. We can accept up to 120, but less than 120 is bradycardic, and above 160 beats per minute, that's tachycardic or increased heart rate.
Yeah.
Both of which are warning signs.
warning
Danger
signs.
signs that the baby may be in
In
distress.
distress. Exactly.
Yeah.
Exactly. And that's good to know. And that's why we look
Yeah.
at it over a
A
period of time. Yeah, to see what is the baseline heart rate of the baby, and what would be causing it to increase or to decrease.
Yeah.
But that's true.
Okay.
Mm.
All right. So you've talked about what is done. You said CTG. We've talked about VE. In this season
Yeah.
of
Yeah.
COVID.
Yeah, so in the season of COVID, for all mothers, they are required to do a COVID test. Of course, if you've come and you're in labor, it will be done there on the labor ward. If you've come, and we'll discuss induction or elective CS or whatever procedure, it's done before.
Okay.
Yeah, just so that we are sure. It doesn't mean that no one is going to conduct labor for you and delivery and so on. It just means that it's good to know so that everyone protects themselves. Yeah.
So you've done your VE.
Yes.
So I'm either like 2 or
4, yes.
So what does that
Or closed.
mean? Yeah, or closed.
Yeah.
What does that mean in terms of labor?
So in terms of labor, there are different stages of labor. That's now what we'll get into. There's a first stage of labor, there's a second stage of labor, which is now the delivery process, and then there's the third stage, which is immediately after delivery.
Okay.
So the first stage of labor is now the one where people are having the labor pains and so on. And the first stage is divided into 2. So there's the latent phase, which is early labor, and then there's the active phase of this stage 1, which is now the active labor leading to delivery. So this latent labor, you could be 2 centimeters. That's considered latent labor. Actually, 2 centimeters up to 6 nowadays. It used to be 4 centimeters, but it's 2 to 6 centimeters.
Wow.
Is considered latent labor, which means it is early labor. You can't really well, you can't really predict how long it's going to take, but let's say on average, it could, even if it takes 8 hours, that is okay. And that is very normal and it is fine. So that 2 centimeters to 6 centimeters is latent labor. And then now from the 6 centimeters, although it varies, to be honest, from hospital to hospital, because the 6 centimeters is new research. So some people say 4 centimeters is what we call the active labor. But the 6 centimeters means it's active labor. So the expectation is that someone is going to dilate at a rate of 1 centimeter every hour after their 6 centimeters.
Right.
And so now you're able to sort of time. If you're saying 1 centimeter, and the aim is to get to 10 centimeters, which is now fully dilated. So if you're 6 centimeters now and you want to get to 10 centimeters and it's 1 centimeter per hour, that means 4 hours. It will take about 4 hours for you to get to full dilation or to second stage of labor. So that's what we use as a timeline. So active labor is more predictable. It's something that we are able to quantify even more, to count. But the early labor is one that might take time, and many people are not that patient during that time. They're wondering, why am I was 2 centimeters then, I'm still 2 centimeters now. And so on. So those are that's what we define as latent labor, and then now active labor.
Okay. All right.
And then now second stage, which is the second stage of labor, is now when you're fully dilated, and then now when you're pushing after that to push out the baby, if you're pushing out the baby. And then third stage is now delivery of the placenta and everything after that.
Okay, great. So when we're still on that topic of labor, maybe you can explain what induction of labor is and what is augmentation.
So induction of labor, people always confuse the two between induction and augmentation. So induction is literally inducting, starting your labor. It's for someone who's not in labor, but they've been told you want to start the process for them for whatever reason. Either they have, an illness, they have maybe gestational diabetes and they need to be induced a bit earlier than their due dates, or they have high blood pressures, or there's just a reason. There's always a medical indication or so for you to be induced, and then also if you are post dates. So if you are post dates, which means you've passed your expected date of delivery, you'll also be called to come for induction. The reason being, after that date, the risks are a bit higher of your baby being stillborn, or there being a death, or there being an issue with your baby. So we tend not to allow a lot of time to pass before we ask you to come to induce, to start off your labor. So there are many different ways that we do it. We won't get into it now. There's the tablets and so on. There are different things, but that's really just starting off your labor. So the basic thing is that it doesn't begin with pain, because people usually think when we say induction, it means we are putting them on the Syntocinon on drip and immediately they're getting contractions. Not necessarily. Most of the time it's just ripening and softening your cervix so that your body sort of begins the process on its own. Then augmentation is when you're in this active stage of labor and your contractions are not, you're 6 centimeters, but you're not really having contractions. So you need some help along the way. Otherwise, if we check you in 4 hours, you might still be those 6 centimeters. So that's when we give you a drip known as the Syntocinon drip. And now that drip now causes your uterus to contract more frequently with a bit more intensity. So that's the difference between augmentation. Augmentation is done by the drip, and it's done when you're already in labor, and then induction is to start off your labor, and it's usually done by different things. It can be a tablet, it can be a gel. For women who have a scar, it can be a catheter. It's done over time. It's done over some time. So induction can even take up to 24 hours, which is very normal.
All right. And then now we come to the second stage, or the stage of delivery. So what are the ways of delivering a baby?
So before we even get there, usually now when people are in this established first stage of labor, there's pain, of course, because of the contractions.
I forgot the pain. How can I forget the pain?
You went through it. Did you go through the pain?
Did.
What? I didn't.
You didn't go through the pain.
I didn't. Mm.
You didn't go through the pain.
Yeah.
Anyway, for me, the pain started later, so I didn't experience it for too long. I thank God.
Yeah.
Hey, but the pain is real.
What?
Yeah, please talk about the pain.
Yeah,
Pain relief.
yeah, because that's the main thing. Actually, to be honest, it's painful. Mothers are just thinking about the pain and the baby, but no other story. So when they're in established labor, these contractions tend to progressively get more and more painful. It varies. We cannot put like what time this person is going to go into pain and so on, but pain is there. So there are different ways of pain relief. The one that is the most effective, where you will probably be feeling just pressure and tightening only, and you will not be feeling the pain, is an epidural analgesia, which is becoming more and more common in our settings nowadays. People used to be very scared of epidurals and believe that they get paralyzed immediately and so on and so forth, but it's very safe. It is usually done by an anesthetist. That's the number one thing. And then they administer. So they put a needle in your back and then they give you the medication. Then you don't feel, what you do is you don't feel the pain, but you're able to sit up, you're able to move around actually, but you don't feel that pain. So that is the most effective pain relief during labor, to be very honest, and it is actually safe. The only disadvantage is that it tends to be expensive because you're paying for the anesthetist and you're paying for the medication, and the monitoring and so on. And most insurances tend not to pay for epidurals. It's not covered. So what we say is that we can discuss it. You discuss it during your antenatal period, see how much it is, and then just budget for it. You can budget for it slowly until the time that you come for delivery. Because it tends to cost maybe between 50 to 100,000 depending on the setting where you are and so on and so forth. So save that now to have that epidural, unless now your insurance covers you. So that's what we would say. So that's epidural, but there are other forms of pain relief that we can give. There's an injection, an opioid injection that we can give you. It's given, but the disadvantage is that it can only be given around 8 hourly. That's the first thing. Secondly, the effects are that someone will tend to feel drowsy. They can feel drowsy, or they can feel nauseated, or even vomit during that time, although we give drugs to counter it. And then it's not 100% pain relief the way an epidural is, for sure. I usually say it's less than 50, but that's not scientific, it's just by observation. There's something else that we can give, which is the gas, Entonox gas, which is nitrous oxide gas. That's also an option. Again, the same kind of effects. You feel very, very lightheaded. It reduces the pain, but only marginally, and not everyone responds to it properly. So those are the other pain relief options, apart from the rest that people maybe will have done from home that as hospitals we don't do. So people talk about, hypnotherapy. People talk about even water baths, although there's the research is not really there, but water baths still seem to help in terms of pain relief, what people have said. People even talk about acupuncture and so on. But the basic ones, when you go into a hospital setting, those are the ones, those three. So that's pain relief, because people always want to know about it.
We've sorted the pain. We've sorted the pain. So now back to your question. So when you were saying now it's time for delivery, and we discuss which ways of delivery. So of course there are two conventional ways. It's either vaginal, it's a cesarean section. Cesarean section it can be elective or it can be an emergency. So elective is you've planned beforehand for whatever reason, and there are very many, but we won't cover them now. So an elective cesarean section, or an emergency where you've been in labor or not, but you've experienced some of these danger signs. There's either bleeding, or the mom is in distress in some way, or the baby is in distress, which is usually seen by the heartbeat fluctuations. So we take you for an emergency cesarean section. During the emergency cesarean section, there has to be an anesthetist, and you discuss what kind of anesthesia you get. Most likely to be what we call spinal, where you don't feel anything from the tummy downwards. It's very hard for you to even move your legs. So
that's the emergency cesarean section. It's usually done, the baby is out, you're usually awake at that point, so you'll be able to see your baby and so on.
Yeah.
Then we go to now vaginal delivery. So vaginal delivery, depending on your setting, everyone just prepares for delivery. Either you're taken to a delivery room or the delivery is done within the room that you're in. So when that is happening, even the way you're breathing is different, even the pain that you're experiencing is different, because now you have an urge to push.
Yeah.
You have an urge to either poop or push, but you feel like something just has to come out. So it's usually extremely different. The pain is very different, and and your body automatically even goes into that mode of it wants to push something out. In hospitals, again, we can allow you to labor in whichever way, but the time of the baby's head actually crowning, or now you're pushing for the baby to come out, we usually expect you to be on your back, so for better visualization and so on and so forth, to now push the baby out. And this is where your birth partner is very important. You will have definitely a midwife there with you and your doctor and so on to guide you through it. But it's important, that support, and to be in that frame of mind to be able to push, because now you're trying to push out this baby. They are allowed it can take even an hour or more for you to be in that pushing phase, and it's actually normal for as long as the baby's heartbeat is fine. And then you push the baby and it's okay. Many people ask about episiotomies. Is it a must? Episiotomy is basically cutting of the the vaginal skin and muscle to allow for there to be space, so that the baby can come out. So we assess and see. Most of the time when we do episiotomies, it's just you assess and you feel maybe the space would not be enough, although generally muscles tend to relax, so it's fine. Or if you're doing like an instrumental delivery, like a vacuum, which I'll mention just briefly later, then we do an episiotomy. So we cut that area after numbing it, and then now it allows for your baby to be delivered. So that's vaginal delivery. During the vaginal delivery, most of the time we are constantly listening to the baby's heartbeat, because it's good to see. Sometimes babies are distressed by the actual act of being pushed out. So that's what we talk about when it comes to vaginal delivery. Sometimes when things may change and you might need a little help for that baby to be removed, so that's when now we do what we call an instrumental delivery, which can either be a vacuum or a forceps delivery. We don't have those things, so people will not know. So a vacuum delivery, basically we stick something on the baby's head for suction and then pull out and help you to pull out the baby's head. That's usually reserved for when there's, the baby's heartbeat is not good, or you've been pushing for very long and there's no real, effort in terms of pushing the baby out, or a forceps delivery. But those are what we're talking about here is just the basic stuff. The basic stuff in terms of delivery.
There's something I've remembered. There's also the supporting of the perineum that you do as the baby is coming out, so that it prevents tears.
To prevent tears, So it's again varied. Research came out that said a hands-off approach is still helps, where you just watch the baby's head come out and it's fine. But commonly people tend to just support. It's a way of controlling and just trying to ensure that you don't get tears. But sometimes even with support, the tears are there. So research is, has just shown that hands-off is still okay. And we are talking about tears. So an episiotomy is like a planned tear. But sometimes the passage of the baby's body and head will cause for there to be a tear at the perineum. There are different types of tears, again, different grades. There's, a first degree, which is just the vaginal skin and surroundings, the perineal, and then now second degree, which includes the muscles. And then third degree, which now includes the anal sphincter. Anal sphincter helps you to control, your pooping or not pooping, and so on. So if that is destroyed, when we get to that, that's usually serious. That's more intense. It takes a lot more repair, which sometimes is done in theater. So ways to prevent that, of course, we've talked about now. Maybe an episiotomy, trying to support, trying to gauge, but sometimes you can't 100% prevent that. And so it will just lead to that. But the goodness is there are always ways to repair and people recover from it. Yeah.
Okay.
Yeah.
Good. Okay.
Yeah.
So now I talk about the part where I receive the baby.
Yes.
Yeah.
After the delivery
After
of the placenta.
delivery of the placenta.
That's it. Yeah.
Yeah.
Just delivery
after-
of the placenta,
yeah.
and that's it. I mean, it's normal. It's not painful.
And
You
that's
just feel
that's
like-
when you also give some medication at that
Yes,
point.
yes, to help the uterus contract,
Contract.
so that you don't bleed as much. Usually it's an injection on the thigh, or if you've already had syntocin on running, it continues just to help that contraction. So and then the placenta is removed, and maybe
Okay.
some clots are removed, and that's the time now the mother is being evaluated for tears and all of that.
Okay.
But behind the scenes, or in front of the scenes, now this baby has been delivered.
Yes.
Yeah, so now this is where I want you to discuss from
What
when the
happens?
baby's head is even out.
Yes, yes, yes.
Yeah.
Okay. So when we start seeing the head crowning, that's when we start getting excited because we know
Yeah.
hopefully in a few minutes
Yeah.
we'll have a baby to receive.
Yeah.
So normally when we're doing it, we have a place called a resuscitator, which is just a station
Yeah.
that has an overhead warmer and a high sort of table that has all the instruments that we may need for this baby, and it has something to deliver oxygen by a face mask,
Okay.
something we call CPAP. And then we also have a suction machine in case the baby has secretions that we may need to. So the baby's head is there crowning, then mom pushes, the baby comes out and hopefully cries immediately.
Yeah.
If the baby, depending on how the baby comes out, if we quickly glance,
Yeah.
if the baby has good tone and has already started crying and is already turning pink, we may want to delay cutting of the cord.
Yes.
So that's when I'll be like, Lisa, wait, don't cut the
And we're
cord.
usually so impatient because we're like,
The obstetricians
"Oh."
get the baby and they just
You
want
want
to
to
cut,
cut,
but
yeah,
we
yeah.
should give it at least 1 minute,
Okay.
delayed cord clamping,
Yeah.
so that you can allow adequate transfer of maternal blood.
Yeah. Yeah.
It's important because it prevents anemia in the baby, and it also helps the baby adapt well to life, extrauterine life. So you want to practice that delayed cord clamping for a minute, 60 seconds, but only in a stable baby. If the baby comes out flat, that's okay. You can cut the cord immediately so
Yeah.
that we start resuscitating.
And by flat, what do you mean?
By flat, we mean that the baby is floppy,
Yeah.
has no tone, is blue, is not crying,
Okay.
is unresponsive.
Yeah.
That's the baby you want to clamp and give immediately.
Okay.
But
Yeah.
if the baby comes out, has some tone,
Yeah.
is crying, maybe is pink, but the extremities are still blue, that one we can give some time.
Yeah. Yeah.
And then ideally, while you're doing that delayed cord clamping, you can place the baby on the mother's abdomen
Yeah.
for skin to skin,
Yeah.
for warmth of the baby. That's
Yeah.
also recommended. And then at the end of 1 minute, you want to now cut the cord, and then now the obstetrician hands over the baby to the pediatrician. And then at that point, we're doing our UPGAR score while we dry and stimulate the baby. So basically, an UPGAR score looks at how the baby will score at 1 minute. So basically, within that minute, when you're doing the delayed cord clamping, you're already assessing the UPGAR score.
Yeah. Okay.
So the score is up to 10,
Okay.
and it looks at the appearance of the baby, the pulse, the grimace. Grimace is the face the baby is making. So if they are crying, there's an obvious grimace.
Makes
Appearance,
sense.
if they are pink and they have maybe some bit of blue, that's not bad. Pulse, we get it once we have the baby, we feel for a pulse. And then respiration, if they are crying, they're obviously breathing.
Yes.
And then we also look for activity.
Yeah.
Sometimes they kick or
Yeah.
they're just, a bit active.
Yeah.
So we do that score at 1 minute, at 5 minutes, and at 10 minutes. Basically, we want a good score of above 7.
Okay.
Yeah,
Yeah.
above 7 in 1 minute, and then subsequently
Yeah.
8 at 5 minutes and at 10 minutes. If the baby gets a score of less than 7, especially at the 5-minute mark. Those are babies that we want to assess further, because that means they haven't quite adjusted well. Or for example, if the baby comes out flat, as I talked about, floppy, that will give even a score between 0 and 3. Those are babies who are very sick and we need now more intense intervention. But basically for our routine newborns, we want them to have good scores above 7. And then once we've done the APGAR score, remember we are doing the APGAR score continually as you're drying and stimulating. So we dry the baby, want to dry the liquid, the liquor, and then there's also a thick white covering, thick white covering all over, which is beneficial.
To
I know
babies.
The moms are usually like, why is it they wipe nicely?
Clean this
Ama,
baby.
can the baby be bathed? No, we don't bathe babies in the first 24 hours. That's Vernix, it's called Vernix. It's actually very beneficial. It has immunological properties. So it acts as a barrier for skin infections. So you don't need to rub it off. You're just drying to remove the moisture, but you don't really need to remove the Vernix. So after we've dried and stimulated, and we've now cut the cord and put a clamp, a smaller clamp. We'll take the baby's weight measurements. We'll take the birth weight, the head circumference, and the length. So that we are ideally supposed to plot these values on a graph, so that you can tell where the baby falls. Is the baby average? Is the baby smaller than usual, or larger than usual? But generally, as a guide, we usually say normal weight is between 2.5 kilos to 4 kilos. So 2,500 grams to 4,000 grams. Less than 2,500 grams, that's a low birth weight. And then above 4 kilos, 4 kilos and above is a large baby, large for gestational age. But generally that's what we do. Then we give vitamin K. Vitamin K is given to prevent disease of the newborn called hemorrhagic disease of the newborn. It's given because their vitamin K levels are generally low, because their body is still immature. So we give it now to protect against that. So
which is now bleeding.
Basically. Bleeding. So it's very important to make sure your baby gets the vitamin K. We also give something for the eyes to prevent eye infections called TEO, tetracycline eye ointment. And then we can also clean the cord at that point with chlorhexidine or surgical spirit, which you'll continue until the cord falls off. And then, so we've taken the measurements. You can now dress the baby and keep the baby warm. So ideally, you should have a cap for the head and some socks, and then just dress the baby and swaddle the baby, maybe with a light blanket and then a heavier blanket. And then once the baby is warm, and we're still within minutes of delivery. We want to sort of initiate the breastfeeding within an hour. Within that first hour
of birth.
So by now you should have sorted any tears. I've given you enough time to
sort
finish
those things
with mom,
out.
so that within the hour she can do skin to skin. Now the baby can be placed on her chest, and then initiate the latching, so that baby can latch and start breastfeeding. Ideally within an hour. I
mean, so that's ideal for a vaginal delivery. But now CS delivery, will it will it affect now the breastfeeding or the breast milk production? Because maybe, of course, the mother might not have a chance to have that skin to skin within that hour. It might be many hours. And this I'm also asking from now my own experience with CS. It took a while. In fact, now it was an emergency CS. Baby is delivered. Baby was taken to the NHDU because he had breathing issues. So by the time I saw him was, maybe 8 hours later to establish that. And there were issues with breastfeeding. But I don't know does it make a difference?
Yes.
Is it, and then how can it be corrected?
Okay, that's true. That's a normal observation. Because now when you're done a cesarean section, obviously you will not be able to do skin to skin immediately, and you will not be able to initiate breastfeeding within an hour. So it's normal. It's normal. The letdown may take some time.
Okay.
So generally it's just to encourage moms. It can be quite distressing.
Yeah, for sure.
Because you're like, the baby has not fed. But it's not possible because you'll have to recover from the CS. So you'll probably be on pain medication. So the idea is as soon as mother is ready, as soon as mother is walking, once you're able to start walking and once you're active and awake, you can just fix on the breast. Even if there's nothing, that action of sucking, that frequent sucking will just stimulate the breast milk. So it's just understanding that at the back of your mind, it will be delayed, but it will get there.
It will get there, That's encouraging. That's very encouraging. Good stuff. So I don't know if I think we'll discuss things like even cord care when you get home. And bathing the baby and what lotions and all of that. I think in another segment.
setting. I think we've talked about the basics.
The
basics.
Important.
Maybe you can tell me your story, then I tell you mine. And this.
That's true. I think I experienced, not many of the things. I think I experienced what I didn't envision myself experiencing. I thought, I'll just go into labor and then things will be fine. And so my due date came and went with no action whatsoever. Just the usual false contractions. You get a bit excited, nothing has happened. And then 5 days later, I had to go in for induction of labor. So I go in for induction, which I had explained is starting your body off. So of course there's no pain. A tablet was inserted for me.
So you were closed?
I was closed. I think if I was open, maybe at best 2 centimeters, but there was no contractions, nothing. So a tablet was put, was there, enjoyed my dinner, watching TV, sitting there. I think I had 1 or even 2 visitors. All exciting, imagining what's next, and then I think now after like 8 hours, time for my next check. Maybe not even 8 hours anyway, I don't remember that time. But then now they check the baby's heartbeat, and the baby's heartbeat is just low. So it's like, we need to prepare for an emergency cesarean section. So immediately things just happened. You signed consent to say you're okay with going in. You're told about the risks, which is also something scary. And then I went in for my cesarean section. So I was awake during that time. I was under spinal. It was very nice, actually, to be honest. It was nice to not feel the pain and then to be awake to see that my baby was okay. So I think I was just holding my breath until I had the baby sort of cry. Then I was like, okay, thank God, my baby is fine and everything is okay. But then he had breathing issues. So now he had to be taken to the NHDU and then I'm taken to recovery. You're very drowsy, very sleepy, out of it, foggy, so I remember just, tossing and turning until now he was brought to me. But even the time in hospital, I think I was still a bit groggy, to be honest, and just foggy because of the painkillers and everything else.
Really?
And it was difficult to initiate breastfeeding. I didn't have milk, I think, for 1.5 days. And then the time that there was milk, I was trying to figure out how to get him to latch. Because babies are also learning how to breastfeed. It's not just the mother who, has has to learn. Even the baby is undergoing a learning curve. So that was frustrating. We actually got to the point where he had to be put on formula, which I went home with. But I would say 2 weeks after being at home is when now the breastfeeding was established.
Yes.
And to this day, and he's almost a year now, it's just breastfeeding for him.
That's
good.
That's
So
good. Yeah.
so that was my experience. Induction, CS, spinal, lack of breastfeeding, just the whole plan was just not there. But I thank God it sort of worked out. And I wish I was also told that then, that it's okay. So you've had a CS, it's okay.
Yeah. It's normal.
It's normal, it's fine. He hasn't started with breastfeeding, you don't have milk. But eventually it will come, and even if it doesn't, and you're a mother to a formula-fed baby only, it's okay.
It's fine.
It's very fine.
It's one of the important things we need to tell our patients, of being open-minded. Like, you can have a birth plan, and actually things can go haywire.
Yeah, for sure.
But at the end of the day, you just want a healthy mom, a healthy baby. And a happy mom and a happy baby.
For sure.
And a fed baby is a happy baby.
That's true. That's true.
So give yourself grace.
And you?
Oh, mine was very interesting. Because I was actually booked for induction. So the day I was told to go to hospital, I went thinking that I would be induced. But it was a Sunday evening. But now Sunday, the whole day, I'd been getting some tightening on and off.
But not pain.
And I knew it has to be regular. It has to be painful. So I was like, these are not regular cramps. And I'm not in pain. I just feel tightening, then it goes. Then again it comes, then it goes. So I didn't think much about it. So when we got to hospital, of course, I needed to have a vaginal exam done now before they start the induction. So when they do the vaginal exam, I am 4 to 5 centimeters.
And this is your first baby?
And this is my first baby. So I was like, oh, really? So I'm already in labor. Okay, that's good. So when I got to hospital, it continued to sort of increase, now the tightening, but the pain was still very, very mild. It was bearable. And I remember I was walking a lot. I was really happy. I was just feeling, really nice. And whenever they would do the VEs, I was progressing. So they would do, now I'm 6 centimeters.
Wow.
Then I'm at 8 centimeters, and I'm walking. I'm just, feeling
the pain
good.
Being very
minimal. I was not on any pain medication. So now at 8 centimeters, that's when they were like, now we need to speed things up. So we'll do a rupture of membranes, artificial rupture of membranes. So that was a bit uncomfortable. I don't know why, but I remember, ow! So the VE is done, and then they poke. They burst the membrane and
they scratch it.
They scratch it, and the liquor now comes out. So now that's when the pain started building. And even like you, I had a birth plan because I had known I'm going to do an epidural.
Oh my goodness,
But my doctor came at 4 centimeters, looked at me, and he was like, I don't think you need an epidural.
You're not in pain.
I'm not in pain. And I was like, you know what? I'm not in pain.
Yeah, that's true.
So the pain started at 8 centimeters, and since I was almost there, they were like, I think you can handle this. But it was intense because,
my goodness.
So after doing the rupture of membranes, I was put on the drip, syntocinon drip.
Oh my goodness.
And it was something. It was an experience.
Oh my goodness.
And unfortunately, I stayed at 8 centimeters for like maybe 2.5, 3 hours. And by that time I had it. Like, I was getting tired, and then the baby's heart rate started to go down. So apparently his head was not in the proper position. But I remember feeling so much relief. Now when I was rushed to theater, and they put the spinal, because it was immediate relief of
the pain.
And then I remember like 10 minutes later, I had the baby cry, and I was like, I've struggled for 2.5, 3 hours
Yeah.
of intense pain
Yeah.
for 10 minutes
Yeah,
of
that's
just
true.
poof.
And the baby's out and
So the baby
crying.
was, but we thank God.
Yeah.
Yeah, he came out well, and there were no issues.
Yeah.
So that was
That's
my
nice.
birth story.
Yeah.
Story.
Birth plans down the toilet.
Yeah,
But it's okay.
yeah, but just go with an open mind
Yeah.
and trust your doctor. I think
Yeah.
that's very important.
Yeah, that's true. That's true.
To just trust your doctor, trust their judgment.
Yeah.
Because if I had insisted and said I have to do it vaginally,
Yeah.
who knows what could have happened.
Yeah. That's true.
Yeah.
That's true.
Yeah.
Oh, nice.
Yeah.
Okay.
So we've come to the end.
Yes, we have come to the
Yeah,
end.
that was
it was a
nice.
good one.
Yeah.
Yes. So if you guys have any questions, we didn't cover complicated births, complicated stories, illnesses, and all of that. But if you have any questions, just let us know in the comments.
Yeah.
Kindly.
Yeah.
Subscribe to our channel.
See you next
See
time.
you guys next time.
Sawa sawa.
Bye-bye.